Welcome to SpectraCell's Thursday night webinar program. Tonight we bring you Sleep, Why It's Vital to Your Health, presented by Dr. Jose Colon. A copy of tonight's slides will be available upon request by emailing webinar@spectracell.com. Other resource materials are available in the resource list on the left of your screen. We will try our best to answer any questions that you have. At this time, I would like to welcome Dr. Jose Colon.
Hi, how you doing? I'm Dr. Jose Colon. Nice to virtually meet everybody over here. And tonight we're going to talk about sleep and why it's vital to your health. So I don't have any disclosures to give. I don't receive any funding through pharmaceuticals. I'm employed by Lee Health. I am an author and have a website that provides sleep health information. And I always put a picture of my kids before every talk that I give, to say that if there's one conflict of interest that I have, it's that I'm a father and I'm a husband. And with every talk that I give and book that I write, I hope that it makes the world a better place for them. So in the objectives, we're going to talk about Sleep 101. We're going to learn more about what normal sleep is. We're going to discuss effects of sleep deprivation on our health. And we're also going to learn about signs and symptoms of identifiable sleep disorders. Part of my background is I'm also a member of the Institute for Functional Medicine and bring a functional medicine approach to my clinic patients. So we're going to outline how some of these concepts fit into general wellness. And this is a part one of two, and in part two, sometime next month, we're going to discuss the role of phytonutrients in sleep as well as benefits of micronutrient testing. So taking the functional medicine matrix into view, we're all like-minded people. And we don't just think of health as different organ systems. We don't think of the heart or GI, but we actually think about how everything interacts together. And within looking at the functional medicine matrix, there's concepts of physiology and function that we talk about within assimilation, defense and repair, energy, biotransformation and elimination, transport, communication, and structural integrity. And within the core of this, there's also aspects that affect us mentally, emotionally, and spiritually. And as we go through and take a history and put pieces of the puzzle together, we see antecedents, triggering events, and mediators. Along the lines of health and wellness, we also have modifiable personal lifestyle factors within sleep and relaxation, exercise and movement, nutrition, stress, and relationships. And as we go through tonight's talk, we're going to talk about different aspects of how this affects our general wellness through the functional medicine matrix. So I'm going to go over a top 5 things that most people don't know about sleep, but many docs don't know this as well. And one is that nobody sleeps through the night. Also, an untreated sleep apnea is as dangerous as smoking. Narcolepsy commonly presents in youth or as insomnia. And medications are not first-line treatment for sleep. And also, sleep loss equals money loss. I can give all the statistics that I want. People relate to certain things better, and money is one of those. So we've learned more about sleep over the last 60 years than the preceding 6,000. But what exactly is normal sleep? And it's interesting how I hear people craving sleep and crying for sleep. But it's one of the basic functions that we're born with. As an infant, we were born to survive, and we're born with a couple instant reflexes. One of them is feeding, digestion, and the other one is sleep. So this is a normal night's sleep, and I promise that this is going to make sense, okay? So if you're not asleep, you are awake. See, I told you this will make sense. Later at the end of the evening, we do wake up, and we have these wake periods during the evening that are actually completely normal, and they're so normal that they have a name called NWAC, or number of wakenings. And if someone's waking up 4 times a night, that's actually normal. Now, just like a washing machine has cycles, our sleep has cycles as well. Now, we have this cycle of sleep called REM, rapid eye movement, and it's our dream sleep. And many people think that it's a deep sleep, but it's actually not. It's a very active brain time. Our brain is almost as active as it is during wake. We're taking today's information and we're emotionally storing it into long-term memories, which explains why you may dream of someone that you haven't seen in a year or a place that you were just in a day ago. So just like a washing machine has this active rinse and spin, we have this active sleep called REM. And you don't just start dreaming right away. You hit your first REM period after 90 minutes, and then every 90 minutes afterwards, you hit another REM period that's even longer, which is why sometimes as your alarm clock goes off, you're like, oh, that was a good dream, because you have more REM periods in the second half of the night. Very powerful information is that we have testosterone rhythms, and the peak of testosterone flow actually comes within the first REM period. So we have pathways of testing people's hormones and everything, and before supplementation, hey, let's take a look at sleep. Also, we have in our REM sleep, our heart rate is accelerated, and we have more blood flow through the body, more blood flow through the organs for tissue repair. And you actually burn calories in REM sleep, and you have more REM in the second half of the evening, which can partly explain why if we sleep a little bit less, we're burning less calories. Now we have this other stage of sleep that's not REM, and that's exactly what it's called. It's called non-REM. I told you that I would make this easy to understand. And we cycle in between these as the night goes. Now, just like a washing machine has a deep soak at the beginning for that deep cleanse, well, our brain has this deep sleep as well, and our brain waves are working really slow, and that's why it's called deep, slow wave sleep. And this is the most refreshing part of sleep, and it occurs within the first kind of 3 to 4 hours there. So we have the glymphatic system, which is a functional waste clearance pathway for our CNS. Cerebral spinal fluid flows through the brain and clears out toxins through a series of channels that expand during our deep, slow wave sleep. Also, we're secreting growth hormone during that deep, slow wave sleep period. And in normal sleep, at the beginning, we start with some digestion and also with some protein synthesis as well. So you can see how this has a nice effect where at the beginning you're forming these proteins, and then the second half with REM, where you have more blood flow through your body, you're starting to repair. So how can this information change my practice, attitude, and habits for tomorrow? You have to think about where's the sleep fragmentation. People say, I can't sleep, or I don't sleep, or I have problems with sleep. Well, what exactly does that mean? Up top, we have a normal night's sleep like I just showed you. And on the bottom, we have an abnormal night's sleep. But there's different things that could be occurring. Some people may have a difficulty with getting to sleep, while other people may be waking up more than what is normal. And then this person, it was never explained to them that waking up during the evening is normal. So when they wake up, they're frustrated, and that frustration keeps them awake longer. And then you have someone with really early wake-up times or short sleep times because of they're waking up earlier. They may have some circadian disturbances. So I'm commonly asked, how much sleep should one get? And there really is no magic number. So it really is different. I like things that are easy to remember, so I'm going to give you a mnemonic that's easy. A 12-month-old should get 11 plus 1, 11 hours of sleep plus 1 nap. A 10-year-old should get about 10 hours of sleep per night. A 9th grader through high school should be getting about 9 hours of sleep. When you have your 9 to 5 job, those 8-hour days, you should be getting about 8 hours. Elderly into your 70s should be getting about 7 hours. And all of these are plus or minus 1 hour, and there really is no magic number of sleep here. So sleep among the ages, and you can see that as you're a young child and you need to secrete more growth hormone, you're getting deeper stages of sleep there, and that's something that you can see that as time goes by, you actually get at less of as deep sleep. And then as time goes by into the elderly, our sleep fragmentation increases. And this could be sometimes from normal physiologic changes, other times from medications or from other aging functions. So that's sleep. Let's take a look at what's going on in the daytime. What makes our sleep drive? So we have this system called the homeostatic process, which involves our body along with our circadian process that takes cues from our environment that together induce sleep onto our brain. And let's take a look at these individually. First, we have the homeostatic process, of which anything that uses energy is going to create a waste product, right? So if you put gasoline in your car, your waste product is the exhaust. Well, our brain utilizes glucose, and it makes this waste product called adenosine. And the names are not important. The concept is that as the day goes by, you accumulate this exhaust, and it leaves you exhausted. And this is why it's hard to stay up past a particular time sometimes. So fascinatingly, that deep, slow wave sleep at the beginning also washes away that adenosine. So that's why even though, yes, we recommend, 7 to 8 hours of sleep, someone's day is not necessarily ruined if they've gotten less because we've had that deep, slow wave sleep. So the other thing that's interesting is that this is where kind of napping can help or hurt us, okay? Naps that are 20 to 40 minutes long can be refreshing, but if you're extending them past an hour, you're getting more into that deep, slow wave sleep. You're starting to wash away the adenosine, and it makes it difficult to get to sleep later. So I kind of relate it as sleep candy. So I don't give my children candy before dinner because then they're not going to have an appetite for a healthy dinner. And likewise, if you're taking long or late naps, that's building sleep candy there. One exception would be athletes. Sometimes do need a little bit longer naps. Just like athletes may need higher calories than the general public, athletes have different napping rules. But that's a different talk for a different day. So another interesting thing is that caffeine counteracts that adenosine. Remember that adenosine makes us sleeping, and caffeine kind of counteracts that. Now, this is true at 200 milligrams and below, okay? 300 milligrams and above, you start to agitate your anxiety receptors, which is why you get kind of agitated there. Now, what's going on in our circadian process? And people ask me all the time, what do I think about melatonin? Well, it's not what I think, it's what I know. Our own brain makes melatonin. However, all day long, light is coming into our eyes, and it doesn't let that melatonin come out. But then, as the night comes by, the sun goes away, night comes, bam, we secrete this melatonin. So we looked at these individually. Now let's look at them simultaneously, how we create this homeostatic sleep drive buildup of adenosine at the same time that the melatonin starts to come out, and that makes the perfect storm for a beautiful night's sleep. Sometimes, however, our sleep-wake cycle can get kind of chopped up. So let's take a look at some examples on how this can get kind of chopped up there. Sometimes people are waking up very early, and if you can see, they have a buildup of adenosine at an inappropriate time, and that results in sleepiness in the daytime. Other times, people may be sleeping in late, and you can see over here that the environment is saying we should be asleep, but we haven't aligned the other process, the homeostatic, our body process. So this results in difficulty getting to sleep or insomnia. Maybe a little bit tired, but not fully to get that nice sleep there. Now, one thing is important to know is that when an adult is tired, they yawn. However, when a child is tired, they tantrum. And nobody tantrums like my little baby girl there. So I see both adults and kids, and this is a common thing that I see is sleep-avoiding behavior when they're tired. So there's ways around that. But then, once again, that's a different talk for a different day. So sometimes we end up with circadian disruption. And this circadian disruption, if we're sleeping in later on the weekends, but we're waking up at different times on the weekdays, that leads to what we call social jet lag. Now, jet lag is not that you got into a plane and then suddenly you're tired. Jet lag is that you're in one time zone, and then you shift it over several time zones. And the signs of jet lag, the symptoms, are fatigue in the daytime and difficulty sleeping. And typically, it takes 1 day to adjust for every 1 hour of time zone that you change. So I'm in Florida. If we travel to California, that'll be a 3-hour time zone change. It'll take me about 3 days to fully adjust. And I typically discuss this with my teenagers and talk to them about the science behind this. And, and then I'll ask them, so you're staying up past a certain time on the weekends? That's like a 4-hour time zone change. How long is it going to take? And they're like, 4 days. And then I'll ask them, what are the symptoms of jet lag? Difficulty sleeping at night, tired in the daytime. And what are you here for? And they're like, okay, Dr. Colon, I get it. However, I did have one teenager that just looked at me in the eye and said, I don't believe you because I don't believe in time travel. Once again, you can't make this up. So how can this information change my practice attitude and habits for tomorrow? Understanding that when you're trying to help patients sleep, the time to start with is actually a wake-up time. Having a consistent wake-up time is going to help them get a consistent sleep time because you're aligning your circadian system to your body process. So what are effects of sleep deprivation? Well, sleep deprivation can affect the mind, cognition. It can impair our immune system, increase risk for diabetes. It can affect our cardiovascular status, decrease reaction time, affect our muscles. We can have growth issues, increase obesity, affect our temperature. How do your clients work? Well, of course they do. And if they're affected by sleep disorders, they can have problems concentrating, handling stress, listening, relating to others, solving problems, decision-making. Now, all of these, however, are statistics, and people don't always, relate to statistics. They're like, whatever. But you know what people do relate to? They relate to money. And sleeplessness costs $150 billion per year in absenteeism, work accidents, and loss of productivity. You know what else people relate to pretty well? They relate to alcohol. Well, let's talk alcohol. They've done studies where they sleep deprive one group of participants and they give another group of participants alcohol to the beyond the legal limit, and then they put them on simulation driving tests. They don't actually make them drive. It's a simulator. And consistently, the sleep-deprived group drives worse. And then they've doubled that, where they've sleep-deprived one group and then give them alcohol, and they do even worse on simulation tests. And if you think about it, when most fatalities occur, they actually occur after midnight. So there's also neurocognitive effects that occur in sleep, and sleep deprivation can be mistaken for ADHD, and that's not my soapbox. That's the National Institute of Health saying it. And inadequate sleep, this can affect children as it can adults as well, and you end up with memory lapses, problems, mood problems, and behavioral problems and personality issues as well. As a matter of fact, I like Star Wars, and I couldn't help notice that Anakin Skywalker, when he was going through Jedi training school, he had insomnia. And I can't help to think that if he would have been read my children's books when he was a young Padawan, he would have never turned over to the dark side. But once again, that's a different talk for a different day. On a serious note, putting all this now on the functional medicine matrix, we've talked about aspects of sleep that when there are problems with sleep, it affects your structural integrity. It affects communication, transport, biotransformation and elimination, energy, defense and repair. And we talked about mental aspects and emotional aspects as well. So now let's talk about certain sleep disorders. Let's first talk about sleep apnea. Now, normally someone has plenty of room for the air to flow, right? However, sometimes that air is not moving through very well. And you can see that this person's trying to breathe, but it's obstructed. And when that happens, it can affect the brain, and that can happen multiple times per night. Now, remember, I said waking up 4 times a night may be normal. However, having brain disruption 5 times an hour or more from an obstructive sleep apnea is not normal. So we can see on the functional medicine matrix there how disrupted sleep or sleep apnea can also affect assimilation in the form of problems with respiration. In kids, sleep apnea is mostly from tonsils and adenoids. However, 2% of children have obstructive sleep apnea, as opposed to 10% have something called primary snoring, where there is snoring but the air is moving through. Not every kid needs to have their tonsils taken out. That's why we get the sleep studies. In adults, it's the retropharyngeal space, or what I call the back of the throat space there, that gets obstructed. And there are different treatments for obstructive sleep apnea. And the goal of this talk is not to make you an expert in these treatments, but rather to see the impact of that. And to do that, we're going to talk about CPAP, which is also called positive airway pressure, okay? And it's pressure that opens up your airway. Now, let's take a look at the effect of CPAP. Up top, we have an untreated sleep apnea. On the bottom, we have the same patient, but treated with CPAP. And let's take a look at their sleep architecture. One, you can see that you reduce the amount of times that their oxygen goes down. Also, they're waking up a lot less. Up top, this guy was waking up multiple times per hour, not knowing it. Also, we don't have a lot of REM in the top slide, but then you give them the CPAP and then bam, they get into what's called REM rebound. We have more of the deep stages of sleep, less snoring, and we get rid of the apneas. And then sometimes we bring people into the lab to find out what the right pressure is. That's what's called CPAP titration there. Now, interesting, the patient up top is the same as the bottom and did not come to me for sleep apnea. They came to me for insomnia. They came to me because their Valium was no longer working for them. But what was happening is that their Valium was making their airway flimsy and making their sleep apnea even worse. They were waking up a lot, but they didn't remember it because the Valium was amnestic. So that's an important thing there. So we see on the functional medicine matrix how having a sleep disorder actually causes sleep deprivation. That patient was not sleeping well because of a sleep apnea, not knowing it. They just knew they weren't sleeping well. But once we got their sleep apnea treated, they started to sleep a lot better and they didn't need their medication anymore. So how common is sleep apnea? Males from 30 to 60 years of age have a 25% incidence of sleep apnea. Compare that to that of asthma, which is less than 5%. How much time of your medical school training was spent in learning about asthma when sleep apnea is a lot more common? Now, after 50 years of age and after menopause, the incidence between males and women becomes the same. And the snoring is not only is it not sexy, but it can, affect your carotid arteries as well. The vibratory trauma increases arteriosclerosis there. It can also actually affect chronic hearing as well. I didn't add the reference to that, but I could provide it upon request. So you can see on the functional medicine matrix how an untreated sleep apnea can cause structural integrity problems with carotid stenosis there. You also have increased sympathetic activity in patients with sleep apnea leading to hypertension. Let's show this to you. Okay, so here is a sleep study that at the beginning there's no CPAP. Later we give it for a before and after picture. And if you look, the heart rate is just under 80 before they fall asleep. But once they're asleep, look how the heart goes above 100. And then when you give them CPAP, look how the heart relaxes under 60. So your heart should be more relaxed in your sleep than when you're awake. But if it's working more, that's not good. You can live this way, but not as long. So this is how an untreated sleep apnea causes problems cardiovascular-wise, and also leads to systemic effects with increased homocysteine and also increased inflammatory markers. Put that on the functional medicine matrix, how untreated sleep disorders lead to problems with defense and repair. And yes, in fact, an untreated sleep apnea has as many comorbidities as continuing to smoke. I once told this to a patient and they said, well, I should have never stopped smoking. That's not what I said. I had to rephrase that. So how can this information change my practice, attitude, and habits for tomorrow? We have to take snoring more seriously. And one thing that I recommend all of y'all to do, and you can write this down now, write down stop bang, okay? You can Google this and keep this in your clinic to ask them these questions. Are you snoring? Are you tired? Have you been observed to stop breathing? Is your blood pressure high? Is your BMI greater than 35? Is your age older than 50? Neck circumference, 17 inches or larger in a male, 16 or larger in a female. And is your gender male? So if you have answered yes to 3 of these, you have an increased risk for sleep apnea, and you should refer over for a sleep study or to a sleep disorder specialist. Now, recently, I gave a talk to the Hockey Summit that was being conducted where I live, and talked to some professional hockey players about sleep and sports performance. Why would I do that? Well, because we mentioned about all the growth hormone and testosterone, and sleep really does affect sports performance. So in taking a look at polls of how much people sleep, we found something pretty interesting here, that the person who was sleeping the most over here was LeBron James. So he's got quite some jewelry there. And who was it over here that was sleeping the least? Tiger Woods. And what have been the 2 things that have impacted negatively Tiger Woods' career? One is poor judgment, and another is injuries. Well, lo and behold, evidence-based medicine, lack of sleep leads to increased injuries. And you can see that student athletes that were sleeping 6 hours per night had higher incidence of injuries than those athletes that were sleeping 9 hours per night. And lo and behold, yes, if you're sleeping less, you're going to have problems with concentration and poor execution when it comes to sports performance as well. So evidence-based medicine there. So sometimes I tell my patients that, they're kind of apprehensive about treatment for their sleep apnea, and if they're male, I'm like, listen, it's going to help your golf game. And that is true. Evidence-based medicine, that when they did a study on PGA golfers, when they found that they had sleep apnea, if they treated it, they were able to decrease their severity and improve their scores. So you can see how this comes onto this functional medicine matrix there, how it affects exercise and movement. Sleep apnea is not the only disorder. We also talk about restless legs and periodic limb movement disorders, so let's talk about some of these. Restless legs are uncomfortable sensations in your legs. They're worse at night, and they're relieved by movement. These are the essential criteria there. Causes of restless legs can include iron deficiencies, renal deficiencies. A number of different nutritional deficiencies can also cause restless leg syndrome. Interesting. We can map that out on the functional medicine matrix, how nutritional aspects can affect our sleep, which affect everything else there. There are some lifestyle approaches to RLS. For example, cognitive behavioral therapy along with exercise together have been shown to reduce RLS symptoms. Also, yoga has been found to be helpful. So I do commonly tell my patients to namaste. Sometimes, unfortunately, they look at me and say, nah, I'm going to stay in bed. But we can see how this fits on the functional medicine matrix there, how exercise and movement are involved, and once again, the emotional component is involved there as well. Now, there's also RLS and GI health. It's been shown that in patients with either irritable bowel syndrome or SIBO that they have more RLS symptoms. So there's a lot of potential mechanisms for this to occur. So restless leg syndrome, I don't view it as a requip deficiency, but as a chance to take a look at more comprehensive things within the body. And that's what we do here on the functional medicine matrix. We can see how it affects assimilation in the form of digestion and our microbiome. Now, periodic leg movement disorder is a disorder that we need a sleep study to identify, because sometimes people's legs do continue to move in the evening. Now, over here, you can see that this person's legs are moving all night long. However, their brain is completely uninterrupted. As opposed to this patient here, that you can see that their leg movements are frequent or forceful enough that it is disrupting brain information there. So this is an aspect that we need a sleep study to get, and there are different treatments for this. Other disorders are parasomnias. Now, parasomnias are verbal or motor phenomena that occur during sleep or during sleep-wake transition. One classification of parasomnias can be our REM parasomnia disorders. Most notably, things that occur during REM, one of them includes REM behavior disorder. Now, when we sleep in our dreams, our body is paralyzed. And it's paralyzed so that you don't act out your dreams. And in patients with REM behavior disorder, they lose the ability to paralyze themselves during sleep. And that can cause some problems. And it is commonly a precursor to Parkinson's disease or other disorders there. So if I'm seeing a patient for REM behavior disorder, I'm not thinking, okay, I just have to fix your sleep. I'm thinking, oh my God, what can we do to change lifestyle factors to help prevent neurodegenerative disease? And when you see Parkinson's patients in your functional or integrative medicine clinics, you should also be thinking, okay, do they have REM behavior disorder? Because we can treat this and help keep them from acting out their dreams and getting basilar skull fractures. On a sleep study, here we have a normal REM where you see the rapid eye movements and low muscle tone, as opposed to this person here that you see increased muscle tone. So this is something that we can evaluate with a sleep study. And sleep and neurodegenerative disorders have interface there. Again, REM behavior disorder starts about 10 years prior to the onset of Parkinson's disease. And then in Alzheimer's, probably about 10 years before that, we have symptoms of insomnia and circadian disturbances as well. So other types of parasomnias are more your non-REM parasomnias that occur more in the deep stages of sleep. Now, in the deep stages of sleep, our brain waves are moving really slow, so our body's not paralyzed, okay? But you can still have a thought, and if you think of somewhere, you may walk there, think of something and say it's sleep talking. And you also can have sleep eating disorders. However, this also needs to be differentiated from nocturnal eating syndromes where someone's just eating more at night. On the functional medicine matrix, you can see how disrupted sleep can also cause nutrition things in regards to overeating. So how can this information change by practice and attitude and habits for tomorrow? Once again, when we're talking about sleep, we have to think about what are we treating. Someone says that they can't sleep, so they take an over-the-counter. All right, well, that over-the-counter has antihistamine in there, which is going to make restless legs worse. People may be taking melatonin. Well, melatonin isn't going to treat an untreated sleep apnea. And then also, like the patient that I had that was taking Valium, that Valium was making their sleep apnea worse. You need to think about what are you treating. Root cause analysis. So my sleep study was normal. How come I'm still sleepy? Well, we may have a disorder called narcolepsy. What exactly is narcolepsy? So it is normal to maybe fall asleep during something mundane. However, if you're listening to an exciting lecture on sleep like this and you're falling asleep, okay, that may be a problem. If you're working on something and you're falling asleep, that can be a sign of narcolepsy. So the most common symptoms are sleepiness, cataplexy, REM phenomenon, fragmented sleep. Let's break these down. To understand these symptoms a little bit better, there is a key point. Let's go back to our basic science. Remember, in REM sleep, we are paralyzed, so we don't act out our dream. In REM sleep, it doesn't normally come until every 90 minutes. In REM sleep, we're learning our memories and we're associating them with emotions. So these are some key physiologic things that occur in REM sleep. Now, let's take a look at those symptoms that I talked about, again, one by one. So cataplexy is emotions inducing muscle weakness. So remember, in REM, we're associating with emotions and our body's paralyzed. So a laughter or anger is going to cause our body to have some of that REM paralysis that we're weak. Now, the stereotype is that of what you see in Deuce Bigalow, where someone just kind of collapses, but that is a stereotype. And more commonly what happens is that their eyelids may be droopy, their head may drop, their arms or legs feel kind of jello-y, okay? This slide talks about what we just mentioned there. So we can see how that maps on the functional medicine matrix there, how emotional factors affect our sleep disorders as well. Now you have to remember there are two types of narcolepsy. Narcolepsy with cataplexy, and that also means that there's narcolepsy without cataplexy. So we'll talk about how to test for this in a moment. But other symptoms can be sleep paralysis, where you're awake, you know you're awake, but your body can't move, like you're paralyzed. So that's that REM paralysis that's coming into your daytime. Now, if you remember what I said, emotions can induce this. So this sleep paralysis can be terrifying, and I explain the science to my patients, and then I let them know. The more that you are afraid, the longer that these sleep paralysis episodes can last potentially. And we work on different ways on getting out of them through emotional regulation as well. So this slide talks about what we just talked about there. Hypnagogic and hypnagogic hallucinations are REM dreams while you're awake, and they are vivid dreamlike images. I've had patients tell me that they've seen spiders or blood and mirrors. I've had patients tell me that they've seen relatives, some alive, some dead. I had one patient tell me that he saw midgets laughing at him. Another patient that was riding his bike, and then all of a sudden he was about to run into a house, so he fell. And then when he looked up, there was no house there. So these are all very vivid images that can occur, and they're not psychosis, they're symptoms of narcolepsy. So this slide talks about what we just mentioned there. And then you can also have disrupted nocturnal sleep. So just like a patient can have REM coming into their daytime in narcolepsy, they can also have wake coming into their REM. And the complaint of insomnia in patients with narcolepsy is actually higher than that of patients who complain with cataplexy, which is the stereotype of narcolepsy. So we talked about that there. Onto the functional medicine matrix, you can see how having a sleep disorder further disrupts your sleep. How do we test for narcolepsy? If you do an overnight sleep study looking for sleep apnea, when you do that, if it's negative, you didn't answer the question as to why they are tired. So the way that you do this is that you do the sleep study, but then the next day you have them take MSLT, or a multiple sleep latency test. Now this is an objective test of hypersomnia, and you're able to objectively see the degree of sleepiness that someone has. Now, if you remember, I told you that you normally don't get your first REM period until after 90 minutes. These are 20-minute naps. Should we have REM in a 20-minute nap when it normally doesn't come until 90 minutes? You should be shaking your head no. The answer is no. And if you do, that is sudden. That is sudden onset of that REM period. And that's how we test for narcolepsy, is that we're seeing the REM intrusions coming into their daytimes. And patients with narcolepsy can have 2 REM periods, 2 or more, and a mean sleep latency of 8 minutes. Now, if you see that guy there is running fast with an eye, so that's rapid eye movement. All right. So now you see how narcolepsy is a disorder of REM, and you can see this Gothic painting of narcolepsy, of sleepiness with sleep paralysis and hallucinations that occurred. When does narcolepsy usually come out? It typically comes out around 15 to 20 years of age. The second highest peak onset is 10 to 14 years of age. So there's this term called pediatric narcolepsy, and I don't like the term because it's like saying wet water. You don't have to say wet water. That's redundant. Narcolepsy is a pediatric disorder. Unfortunately, it's normally not detected until 7 or 10 years after the onset of symptoms. Other symptoms that can happen. Many people have automatic behavior because you do things that when you're tired, problems with concentration. But also visual symptoms can occur, blurred vision. Some people confuse this with fainting episodes. And what happens is that your extraocular eye muscles can have cataplexy as well. Some common misdiagnoses that we see are daydreaming, ADHD, and depression is one of the big ones, because if you just take a look at all the symptoms of depression, you can have all of those if you're having some sleepiness as well. Speaking of sleepiness, what are some other causes of sleepiness? Well, there are predictable causes of sleepiness, such as stress, jet lag, chronic insomnia, but also mitochondrial dysfunction can lead to a lot of fatigue. You can see problems with depression, headache, fatigue, neurodegeneration, of which all of these are also associated and bidirectional with sleep disorders as well. So you can see how that functions out there on the functional medicine matrix, how energy is affected. So there are different treatments for narcolepsy. Some of them are pharmacologic. Other can be kind of lifestyle effects as well. One of these is food, and we recommend low glycemic diets. And let's just think about the basic science behind this. Ghrelin is a hormone that comes out when your stomach is empty, and it makes you more alert, and it makes your stomach growl. And then you eat, your stomach distends, you stop secreting the ghrelin, and then as your blood sugar rises, you secrete more leptin, and leptin causes a feeling of satiety, but it also causes some sleepiness. So one of the recommendations that we have is to avoid high glycemic meals. A matter of fact, diet therapy for narcolepsy, there are a pocket of patients out there with narcolepsy that are doing very well on ketogenic diets, and there is some science to support this as well. And as a matter of fact, patients with narcolepsy commonly also have some mood disorders as well, and ketogenic diets and very low glycemic diet can also improve mood. In my clinic, one of the things that I use is the Mito Food Plan through the Institute for Functional Medicine, and I've had some very good success with this. And that's actually part of what we will talk about in part 2 when we next month when we talk about sleep and the mitochondria as well. We'll discuss the Mito Food Plan. So you can see on the functional medicine matrix how using nutrition can affect our sleep as well as also digestion there. So how can this information change my practice, attitude, and habits for tomorrow? Know when to refer to a sleep specialist. Just as many mainstream docs may be missing subclinical thyroid disorders or adrenal fatigue, likewise, we don't want to be working people up for different functional medicine or for different hormonal things when really we need to rule out a sleep disorder or neurologic disorder such as narcolepsy. So these are just some considerations to keep in mind there. Now, I don't have narcolepsy, sleep apnea, or restless legs. How come I can't sleep? I hear that a lot in my clinic. This is actually the cover of the back of my book, Sleep Diet, which a novel approach to insomnia, which I actually wrote before I knew anything about nutrition, and it's more about behavioral sleep medicine, actually not about nutrition. It's about non-medication approaches to sleep. But what is insomnia? Insomnia is the difficulty falling asleep, staying asleep, or poor quality of sleep, and it's associated with distress and impaired function. How common is it? 30 to 40% of the population has had insomnia at a current time. And then at some time, at least 90% of patients have had at least an adjustment insomnia. Now, the thing with insomnia is that it is not a disease, it's not a disorder, but rather a symptom, okay? An example of that would be fever, all right? So people don't have a fever disorder. No, they have a fever as a symptom. You know, maybe they have a tooth abscess, maybe they have Zika virus. Giving them Tylenol is going to make them comfortable, but you're not getting to the underlying root cause. And the same is true with insomnia. There are medications for sleep, but they're not getting to the underlying root cause. One of the common root causes is something called psychophysiologic insomnia. And I tell my patients, it doesn't mean that we're psycho, but get this. Some people have difficulty sleeping because something's bothering them, and what's bothering them is that they're not asleep. And the harder that they try to sleep, the more exhausted, tired, but wired they become. So sleep and stress are not compatible, and this is true in females as it is males as well. So, on to the functional medicine matrix. We can see how stress affects sleep and how that can affect us in our overall wellness. We have this model of insomnia called the 3P model, that people have predisposing facts. There are genetic factors that we can see, but there's also maybe some habits, some behavioral factors that we had early on, watching TV in the bedroom, some stuff that may not be some good sleep hygiene. And then you have a precipitating factor, a life-altering event. A life-altering event doesn't always, okay, you're being chased by a lion or something. No. You know, worrying about keeping your job is a life-altering event. Worry about infidelity is a life-altering event. These are things that change our lives. And then we can have perpetuating factors or habits that afterwards we learn to associate with insomnia. So you sleep in longer because you didn't sleep in well, but by sleeping in longer, you're having a different wake time that predisposes you to more difficulty sleeping later. So we have this 3P model of predisposing, precipitating, and perpetuating factors that causes insomnia. Look at that on the functional medicine matrix. We have antecedents, triggers, and mediators. So you can see how all of this is starting to flow into our general health and wellness. So there are some treatments. One treatment is cognitive behavioral therapy, which is actually first-line therapy for insomnia. Now, cognitive behavioral therapy is a therapist kind of working with you for insomnia, and I can give you an entire hour lecture on this, but instead, let me just show you this, okay? They did this study where they gave one group of patients an FDA-approved medication for insomnia, and they had lower insomnia scores at 2 months, but at 2 years, it was about the same. They gave another group a combination of medication as well as cognitive behavioral therapy for insomnia. They had lower insomnia scores at 2 months and lower insomnia scores at 2 years. They gave a third group no medications at all, cognitive behavioral therapy for insomnia. And through the therapy, at 2 months they had lower insomnia scores, and at 2 years they had the lowest insomnia scores. So getting down to the root cause is the winner, chicken dinner there. So I encourage you all to learn about the Society of Behavioral Sleep Medicine, which helps teach therapists and psychologists and social workers about cognitive behavioral therapy for insomnia. And refer to them if you have a patient with insomnia. Other things, circadian rhythm entrainment helps reinforce our biologic rhythm. It's a core of what I always start out with in my clinic, talking about the circadian system and how it affects our sleep drive there. Other treatments, sleep hygiene, stimulus control, sleep restriction therapy. I could give you a 1 hour lecture on each one individually. Instead, what I'm going to do is let's lump them all together and say there's a concept of sleep association. Associations are important, okay? And I see this all the time. Someone cannot sleep in their bed. Frustrated, they get up, they go to the couch, they fall asleep. Sometimes the opposite occurs. They're watching television at night. They fall asleep on the couch, and then they get up, they go to their bed. Now I can't sleep. It's because I moved too fast, or there was a light or something. There's no melatonin coming up from the couch. There's no caffeine fumes on your bed. They've learned to associate their bed with they can't sleep. So people always ask me, what do I think about electronics and sleep? The obvious answer is look at what that's doing to your circadian system, okay? But the not so obvious answer, let me ask you a couple questions. Do you drive? Now, when you drive, are you trying to fall asleep or are you trying to stay awake? I hope you said stay awake. When you drive, do you sometimes listen to your radio? Can you see how you're learning to associate that radio with staying awake? Now, let's just say that you were in bed and you're not asleep. Can you see how it may be a bad idea to listen to that same radio station that you associate with wake, Pavlovian? So I ask my patients that question, and then I ask them when it comes to the electronics, do you get on Facebook? Do you check your email? Do you do these things because they bore you or because they're mentally engaging? And patients will always say, yeah, I guess that is mentally engaging. So sleep restriction, stimulus control, sleep hygiene, explanations are more important than instructions. So now these explanations make sense when you think about sleep hygiene. Light, you want dim light activity because you don't want to affect your melatonin levels. Your environment, you want to associate with sleep. Activity, having a routine such as light stretching or yoga or a bath that you associate with sleep. Within your routine, put on your pajamas. If your pajamas are comfortable, don't wear them all day long on the weekends. Don't go to the grocery store in them because then you're going to lose that association with sleep. Napping. Short naps can be helpful, but long naps can be detrimental towards your homeostatic drive. And then substances. Caffeine too late is going to keep you up. Now you know how. Alcohol can loosen your airway and make a sleep apnea worse. And then there's relaxation training, reducing arousal and decreasing anxiety. And here's a picture of my kids. And this looks really cute, but I must confess that this is actually sleep-avoiding behavior at its finest. I told the kids, you're in your pajamas, time to go to bed. And they go, no, Dad, we meditated. And they got onto my meditation couch there. But just like you have a heart rate, we have a brain rate as well, okay? And if your heart is agitated, if you are agitated, your heart is going to go up and your brain is going to arouse. We showed you EEG rhythms in sleep and how they slow down. Now let's just say you're in bed and you're agitated that you're not asleep. Your heart's going to go up and your mind's going to go up. So you can see how if you're anxious that you're going to be tired the next day, you're going to have more difficulty sleeping as well. So all of these things are interconnected. Now, when you do relaxation training, you're inducing a parasympathetic response. And as you induce this parasympathetic response, your heart slows down and your mind is able to slow down as well. Interestingly, in the deepest stages of sleep, our heart rate is the slowest, our breathing is the slowest, and our brain rate is the slowest as well. And you hear many accounts of people who are trying to learn to meditate that they fall asleep during it. So, mindfulness meditation is better than sleep hygiene training, evidence-based medicine through JAMA. And there have been many studies that have been showing that mindfulness is good for sleep as well. So I encourage this and meditate with some of my patients as well and do some community meditations. Okay, where does this map out on the functional medicine matrix there? There on the spiritual and emotional there with mindfulness and contemplative practice. Now, as you can see, we've filled everything out on the map with the exception of relationships. Let's talk about that. But before that, talking back about insomnia, how can this information today change my practice, attitude, and habits for tomorrow? Understand that insomnia is not a night disorder. It is a 24-hour disorder. There are things that happen to you during the daytime that lead to difficulty sleeping at night. And a poor night's sleep chronically can affect your daytime as well. So, back to the matrix model, sleep and relationships. And it's the difference between parts of our relationship and maybe struggles, okay? Evidence-based medicine has shown that when there are sleep disorders, that this negatively impacts the relationship. And whether this is snoring from the male or insomnia from either one of these, when you have sleep disturbances, you negatively affect the relationship. Also, very interestingly, in males, it's been shown that when their sleep efficiency is normal, that they have less negative partner interactions the following day. In females, when there is less negative partner interactions, they're able to sleep better. So there is something here in sleep and relationships. And what about sleep and sex? We hear about this a lot. Both men and women can feel sleepy after sex. There's a cascade of hormonal effects that do occur leading to everything, but in a nutshell, with orgasm, you can have release of prolactin. And prolactin can induce sleepiness. When they've injected animals with spinal fluid with prolactin, you can see that it does induce some sleepiness there. Also, in order to reach orgasm, it is a requirement that you lose fear and anxiety, of which fear and anxiety are not compatible with sleep. And then typically sex does occur in the bed, which we associate with sleep. It could be a lot of activity, so it could leave you tired, and then breathing a little bit faster or longer breaths, which can slow down your heart rate afterwards as well. So you can see how that fits into the functional medicine matrix there, that every aspect of sleep can fit into many different aspects onto the matrix there. So there we have the cat's meow there. Now, in the future, next month, we're going to be putting other pieces of the puzzle together within nutrition, weight, sleep, and energy, and also talking about the mitochondria. For now, I will say, from the father of medicine who said this, sleep and watchfulness, both of them, when immoderate, constitute disease. I want to thank you all for tuning in, and I just want to say to everyone, when we encourage others to encourage others, we make this world a better place, and feel free to contact me if you need to at paradisesleep.com. Thank you, and sleep well.
Thank you, Dr. Colon, for this very informative presentation. We are currently out of time for questions. Stay tuned for part 2 to this series next month. Have a wonderful night.